So my presentation tonight is really going to be a little bit more around data collection when using emerging technologies in rehabilitation. So I'll go through some statistics around stroke and some other bits and bobs, but the later part of the presentation we'll talk about how we actually set up our clinic with virtually no funding. And I think there's probably a few people in this room who are looking at items like the Sabo Flex or the Sabo Rejoice and thinking, it might be great to have in your clinic, but how do we go about getting funding to get it into the clinic? So I'll spend a little bit of time talking about how we did it, as well as giving you some ideas around who to partner with and how you might set up a clinic as well. And before I start, I just want to also acknowledge my co-researchers, and I will talk about how I partnered with them to set up the clinic, and that's the head of Rehab, Professor Fari Khan, and a very famous researcher called Professor Mary Galea, and they were very instrumental in us setting up our clinic and being able to publish on the results of our study. So that's a little bit about what I'll go through, some stroke statistics. I'll briefly go through some neuroplasticity. I won't spend a lot of time on it because Lauren's already given us some nice information on that. I'll talk a little bit about emerging technology research. I'll define it because there's a bit of confusion between robotics and gaming technology, as well as what's published out there and as to whether it is useful in clinical practice. And I'll go through our study and what we measured to determine if it was effective to use gaming technology in rehabilitating the upper limb following a neurological event. And I'll go through a case study. And then I'm going to talk about practice change as well, because I think it's one thing to want to introduce change into a clinic, whether it's Sabo Flex or Sabo Rejoice and any of the other items, but it's another thing to get clinicians to change. Clinicians, whether it's doctors, nurses or allied health professionals, we don't really like change all that often. So I think it's worthwhile discussing how to actually foster that and what you could do in anticipation just to ensure that you have some good sustainable practice change. Okay, so I'm sure some of these statistics are well known to all of us, that stroke's the leading cause of disability in high-income countries and still the leading cause of death in a lot of developing countries as well. Roughly about 56,000 people have a stroke in Australia each year. I think that's 1 every 9 minutes. So those statistics remain quite significant, and whilst we're getting better at managing some of the acute effects of stroke, we've got thrombolysis and we've got clot retrieval, so we've got some fantastic things happening there. There's still a need for rehabilitation. We still have patients who have residual deficits following a stroke. And it still surprises me to know that 30% of stroke survivors are under the age of 65. So stroke isn't a disorder or a disease that's primarily for the elderly. And I was talking to somebody earlier on and saying that earlier on in my career I saw quite a few children who have had stroke. So it's something that can affect anybody at any stage of life. We also know that a lot of patients have upper limb impairment when they present to hospital and they're admitted for stroke. It's nearly 70% of those patients. And of those 70% who have been admitted with some upper limb impairment, 50% of them will continue to have a non-functional upper limb 6 months down the track. And that was probably really nicely illustrated through Lauren's example and her video earlier on of a fellow who I think was 9 months or 2 years post-stroke and really had a non-functional upper limb. And it's something that probably most people in this room see, whether you're working in community rehab or in inpatient rehab. So we know that 4 out of 5 patients will leave rehab with restricted arm function, which is quite significant. And we also know that the impact of the disability on the individual is also quite significant. So the Australian Institute of Health and Welfare, every 4 years or so, they look at some census data, and they found that the top 4 types of disability following a stroke are restriction in physical activities or work, incomplete use of limbs, and that's including the arms, incomplete use of arms or fingers, and difficulty gripping or holding things. We also know that impaired upper limb function following a stroke is associated with a lower quality of life, and it has a strong correlation with depression as well. So regaining upper limb function following a stroke, it's not easy. And I work clinically in the field, and I have for some time, and I know it's not easy. And there's a number of reasons why it presents so many challenges for the patient and for us as clinicians. Firstly, most stroke survivors can do a lot of their activities with their unimpaired side. And whilst this might be useful in the earlier stages, it really quickly leads to non-use. And I cannot tell you the number of patients that I've had come through the door who had a potentially useful upper limb, but they weren't actually able to maximise the outcomes because they moved into that pattern of non-use. They just used their unimpaired side. I think a lot of the upper limb dysfunction that we see come through the door isn't as straightforward as just being motor impairment. Often we're seeing a number of different impairments. There could be sensory impairment, spasticity or hypertonicity, cognitive impairment. So we're usually dealing with a multitude of impairments there, which means that it takes often quite a long time to actually get good return and quite a lot of expertise to be able to bring that out in our patients. And of course, one of the most significant challenges that we face as rehab clinicians is that we have a lack of resources, and that could be to do with time. So I'm not sure about Sydney, I'm from Melbourne, but our length of stay for the inpatient acute setting sits at about 19 days. And when we're talking about rehabilitating the upper limb, we're really not going to get much in 19 days. So with length of stay decreasing, and I'm in public health, so we certainly don't have a lot of funding to really be buying heaps of equipment. We're really presented with some significant constraints to how we go about upper limb rehab. And I'll just go through this really briefly because we already talked about neuroplasticity with Lauren's presentation, but I really like this example, and it's a famous study on monkeys, and I think it was the Silver Springs monkey study that was done to prove the effectiveness of constraint-induced movement therapy. But what we see here with the monkey on the far left is that he's presented with quite a complex upper limb challenge. So that this little bloke is reaching out and he's having to twist his wrist and his hand and really work to get the food item out. It's not a straightforward reach and grasp task. In comparison, his little friend next door has got a far more straightforward task. So you can see the dish that he's grabbing from, he can just really do a gross kind of grasp of the food item there. Later cortical mapping, having a look at changes that happen neurologically to the monkey, we'll see in the first picture of the brain, that the area that is mapped for the digit has much greater representation in comparison to his friend next door. So what that says to us is that a more challenging task is really critical for neuroplasticity. So it's not enough for us to stick our patients on, say, a pegboard and just hope through mass repetition that they're actually going to be able to make cortical changes. We actually have to look at the complexity of the task as well as repetition, frequency and intensity. So neuroplasticity in the upper limb, and again, Lauren mentioned that we have some important components there. The first one being intensity, and I'm really fascinated by intensity. So there's quite a nice bit of research going on around the importance of the number of repetitions. So it's not so much about our patients coming in and having, say, a 30-minute or a 60-minute session. It's about how many repetitions actually complete in that time. We don't yet know what that critical tipping number is, but we do know that it is likely hundreds of repetitions. So intensity is receiving growing attention because it's actually probably more important than frequency. Challenge. So I showed you the picture before of our little monkey mates. Challenge is really important. We need to make sure that our patients aren't doing the same thing time and time again because that won't promote neuroplasticity. And we also don't want to make it so challenging that we don't encourage our patients to achieve some form of success. It's got to be the just right challenge, and making it more challenging as your patients progress. The final one is frequency, and that's how many times a week your patients come in for their sessions. I think in a nutshell, neuroplasticity, if you look at it its most simple form, it's really about learning. So if you think about it when, say, people are younger or children are learning, if they do something once a fortnight, let's say it's a swimming lesson, they're really not going to pick it up, or it's going to take a really long time to pick up. So the same concept for rehabilitation. The frequency with which your patients attend will make a really big difference to those cortical changes. And I'll talk about the frequency that we recommend for our patients when they come in. So given the factors that I've already talked about, so we know there's some really nice studies out there, both animal and human, to suggest that frequency and intensity and engagement are really important factors for cortical changes, for neuroplasticity. And given that we also know that we're a little bit time poor, it's complex to rehabilitate the upper limb, we're kind of presented with a bit of a conundrum. You know, we're presented with a situation where we know we have to be able to provide these opportunities for intense repetitious practice, and yet we kind of don't have the expertise necessarily or the organisational factors to support that. Well, certainly that's a situation we found ourselves in, which led us to start looking at emerging technologies. So we started to think, well, is that a platform to be able to get the repetition that's needed? Is that a way to be able to get our patients to do more practice in an enjoyable sort of format, to be able to actually get the changes that we know are possible that we just weren't getting? So I want to start by talking about what I mean by emerging technologies before I tell you what we introduced and why. I mentioned earlier on in the first slide that there can be a bit of confusion around emerging technologies and robotics. A lot of people think it's top-end robotics, and whilst that does feature in emerging technologies, there's certainly other levels of it as well. So at its most basic form, in that top left-hand side where we see the kid cheering like that, is gaming technology. And that's probably what you see most frequently in rehab centres. So that's stuff like your Wii Fit, Move It to Improve It. The patients typically aren't wearing a headset or using any sort of hardware. It's usually got a Connect type of system that detects where the patient is, and they can move accordingly. It may or may not have software that's specifically designed for the stroke population. I have a colleague who's done her PhD on it, and she had some software specifically designed for it to encourage certain sorts of movements. But things like Wii Fit will still encourage movement, but it won't be stroke specific. Next, we have in this bottom right-hand corner non-immersing VR technology. VR refers to virtual reality. And so that's where somebody might be wearing some sort of a glove, or they might have goggles on, and they get an extra degree of immersion. So usually they get a sense of depth. So rather than that flat sort of 2D thing where you're looking at the screen and you've only got two dimensions, you can reach into it. So we do see that a little bit here in Australia as well. Then we've got in that top right-hand corner, immersive VR technology. We don't really see a lot of that here. That's pretty full on. I've had an opportunity to try it, so I've got some mixed thoughts on it. But it's where you're either in a specifically designed room, or you're wearing the full headset as well as the gloves, and you have the sense of being in the environment. I can't think of what the movie is. It's not Inception. There's a movie where it shows it quite clearly, a more recent movie. And we see that a lot in the States, and they're using that in veteran rehab, and they've found that it has some quite good results. Yet to really take off here in Australia. And then the bottom corner where we see the lady where it says robotic therapy, that's another form of emerging technologies, and typically it's electromechanical assisted. There's a few options with it. You can have full compensation, you can have active resistant, so there's different ways of using robotic therapy. In our clinic, we have gaming technology, non-immersive, and robotic therapy, and I will talk a little bit about the devices we've got. So what's the evidence for emerging technologies? Because it kind of feels like it's sort of a little bit new and modern, and it is to Australia to some degree, but overseas they've certainly been using emerging technologies for quite a lot longer than what we have here. The most recent Cochrane review is 2015, or actually it might be 2016, and they looked at 34 trials. So there is some nice research out there, over 1,000 patients in total, and they found some really good, strong evidence to show that upper limb function can improve through using emerging technologies, and it has a positive effect on ADLs. Now, I feel I need to say here that when these studies compare it to traditional or normal, everyday, conventional practice, they come out as even. Most of these studies won't describe what that practice is, so that's a little bit of a weakness in those studies. Okay, so I'm going to talk about how we set up our own emerging technology equipment at emerging technology clinic and how we collected data to show whether it was effective or not. So in 2013, we managed to get hold of a Sabo rejoice. That's a device you see at the back there. And it came to us by a fairly non-typical pathway, as in another researcher had the device and had been using it with another study and no longer required it, and essentially said to me, "Do you want it?" And I was like, "Yeah, absolutely, I want it." So that's how we came to have our first piece of equipment. So fortuitous, it was kind of good luck. It was a little bit about being in the right place at the right time. It was also about relationships, relationships with different people who might have access to devices. And we had a conversation at that time around, could we actually set up a clinic that would have some devices like the Sabo rejoice, as well as some other low-cost devices based on using gaming technology or robotic technology, and could we in fact build into that clinic data collection so that from an Australian perspective we could show whether it's effective or not. So that's how our clinic essentially started. It was through a conversation, inheriting a device that was possibly going to be put into a cupboard getting dusty somewhere, and deciding that we would find a way to collect data. So we started off with 3 pieces of gaming technology, none of which we paid for, that we inherited. A robotic device was added later, which we also didn't pay for, which we got through a relationship and an agreement to collect some data. We'll describe that more. We set it up as a group treatment program because, to be honest, we didn't have the money to be providing one-on-one therapy. So we had to have a look at what was cost effective because I didn't have any extra staffing. So I had to try and build it into the clinics that we already had. We set it up then as graded workstations, and I will show you some footage in a moment. We looked at having both unilateral and bilateral options for training, and we made some really important partnerships with external stakeholders and internal ones, including my medical colleagues, other companies that were looking at developing products, and we made a bit of a deal. You know, we would trial the products and collect data for them. And the relationships with my medical colleagues were really important in terms of data collection and getting the clinic up and going. So that's one of our more basic devices, and essentially it's gaming technology with a giant mouse, hence the term giant mouse. So it's essentially used for patients who have either just flickers proximally, they may not have any anti-gravity movement, so our heavier sort of patients who are really at the start of their rehab journey. It's essentially unilateral focus, though I have used it bilaterally as well. It's very much looking at shoulder flexion extension, maybe some external rotation as well. The patients play games, and it's still based on that premise of mass practice. Once our patients improve and they're showing perhaps some anti-gravity movement, we would progress them onto the next device. So the other one we've got is the AbleX Professional, and that's where the patients, you can use it either as a joystick on its own or as a bilateral device, and that's where the patients potentially have some anti-gravity movement, or they can use it on their lap if they don't have a lot of anti-gravity movement, but it could be used in standing or in sitting. The third device we have is a Sabo rejoice. We actually have 7 of them now, but we did just start with one. So we've got a Sabo rejoice there, which really covers both ends of the spectrum. So it can be used seated or in standing. It can be used for gross motor movements. It can be used if there's any physios in the room, certainly for some balance and step training. It can have a proximal focus, or it can go all the way down to fine motor grasps, including pincer grasp. Lateral pincer as well. And we also have an Armio, and that's our robotic device. And that also sits in there, and we do use that within our group therapy program for patients who have literally no movement at all, our most heavy patients, or we use it with patients who have an ataxic upper limb. We found it's quite good for that. So when we started our hand hub clinic, we knew we were going to collect data, but I wasn't keen to do an RCT for any number of reasons. For a start, there wasn't enough evidence, certainly no Australian-based evidence, to even suggest there was any clinical effectiveness with using these sorts of devices. Secondly, I didn't want to exclude your typical rehab patient. So my conundrum with RCTs is that the inclusion criteria are generally quite rigid, which they have to be, so that you can prove your hypothesis. But I really wanted to be able to have your typical rehab patient come in, which for anybody else here who works in rehab, what's your typical rehab patient? It could be anything. They could have cognitive impairment, they could have spasticity, they might have had prior strokes, they could be aphasic. So I really wanted to be able to collect data on all of these types of patients, because I was really genuinely curious to know, is it going to work for all of them? What are going to be the factors that are prohibitive versus the ones that are important? So inclusion criteria is, initially everybody wanted them to be able to follow a 2-stage command, and I fought really hard for it to be a 1-stage command, because I feel that the technology actually suits patients who might be really impaired in terms of receptive aphasia. And we certainly were able to prove that the visual graphics were actually sufficient to be able to engage patients with just a 1-stage command. Adequate vision, because obviously most of it is visually related. So unfortunately, patients who have quite significant visual field loss really weren't able to participate in this type of therapy. Pain-free upper limb, not necessarily, as long as it was stable. We certainly had no adverse events, and it certainly wouldn't exacerbate the pain. And I would argue that engaging the upper limb can actually reduce some of the pain experiences we see in that population, and over 18 because we service an adult population. Excluded anybody with uncontrollable epilepsy, because obviously that presents some issues for us in the clinic. Serious progressive disease. So we were a little bit loose with that one. We did have patients with GBMs come through who had excisions of tumours, and they showed some really nice progression. Severe receptive aphasia, if they couldn't even follow a 1-stage command, or severe cognitive deficits. And certainly we had patients who had moderate cognitive deficits and were able to participate. So as you can see, our inclusion criteria are really broad, and I think really reflect the type of patients most of us see come in the door. So the way we ran our clinic is that all of our patients, when they came in, they'd go through a baseline assessment. And this was just such a wonderful way of going about things, because it had 2 benefits. It meant obviously we were collecting data, but it also encouraged our clinicians to ensure that they were taking measurements, doing their outcome assessments and taking baseline measurements. So certainly from a Melbourne perspective, and I think even more broadly in the literature, we know that health professionals aren't always the best at taking their outcome measurements, and there's lots of reasons for that. And this really helped us change our practice. We became a lot more consistent with collecting this data, even for our patients who didn't come through the clinic. And that's really important for future business cases, and I will talk about that in later slides. So they come in and they see an OT, and there were a number of different OTs who would take on that role. They go through the standardised assessments, and we had a range of those. So we looked at motor function using the Wolf. We also used, we started with TARDU, and then we moved to the Ashworth scale because our doctors prefer to use the Ashworth scale. We did some cognitive assessments. We also used functional upper limb measures, including the ARMA, and we looked at goal settings, so we use the goal attainment scale. So these are all pretty typical assessments that most of us would be familiar with. The intervention, as I said before, was run as a group. And I have trialled this in the home, and I can tell you hands down that it works better in a group program than it does at home, which is really interesting. That surprised me to find that. So up to 6 patients in the group, 60-minute sessions, 12 sessions, minimum 3 times per week, and I was pretty strict with that. I wanted the intensity and I wanted the frequency. So if my patients couldn't come in that often, I would question whether they're ready for rehab. And I think you need to be committed to rehab to get the sort of changes that we'll see the patients got. graduated difficulty that I mentioned before. Then we did some post-intervention assessments, which were after they've had their minimum of 12 sessions and 6 months down the track. So this is a snapshot of the demographics. I'll let you know that we've had about 400 patients go through now. So this is our initial data analysis. And we did it quickly and we did it early because we wanted to publish, and also because we wanted the study so we can go and get some money, because data really speaks volumes when you're writing business cases. So the data that we looked at was just under 100 patients. Average age was just over 55, but our oldest patient that came through at that time was 88. And I don't know about you guys, but I really had this perception that it was the type of intervention that would be for the younger population, because you kind of think emerging technologies and gaming technology, it'd be for people 30s, 40s, maybe 50s. And our feasibility data would suggest that it was our older population who loved it, absolutely loved it. And I do have some photos of our elderly fellow who's in that sample group. So we were able to demonstrate feasibility for all age groups. In terms of the diagnoses that came through, the majority was stroke. So that's roughly 88%, but we also had some patients with MS and some patients with brain tumours, meningiomas, as well as a couple of GBMs that I mentioned earlier on. In terms of the types of impairments those patients had, this is typically what you would see in a stroke population. So our population didn't differ to what you would normally see in these types of studies. So, roughly a fifth of them had aphasia, a third of them had some form of cognitive deficits. Typically it was some attentional deficits, some short-term memory deficits and exec dysfunction. And a fifth with perceptual deficits, so things such as neglect or inattention. And so this is some of our outcome data, and we have published on this, and I think I've got it in the reference list at the end. And this is just a snapshot. The entire analysis is in the article that we published. So the important numbers that I want you to have a look at are on the right-hand side, and that's the effect size. And what the effect size is, it measures the size of the difference pre- and post-intervention. And the rule of thumb is that a score of 0.1 for an effect size is small, 0.3 is moderate, and 0.5 and above is a large effect size. So obviously in rehab we're all looking for a large effect size. 0 is at baseline and time 1 is immediately post-intervention. And I've got a few of the measures up there. So we've got our motor assessment scale, we've got ARMA, we've got the Wolf motor function test, and we've got the EQ5D, which is a quality of life measure. And as you can see from the effect size, all of them had moderate to large effect sizes. So if you have a look at ARMA, and ARMA is a subjective measure, so ARMA asks the patient in the last 7 days whether they've used their hand for certain tasks, and it can be things like reaching into your pocket or using a wallet and all this sort of stuff. So it's their subjective perception of how they've used their upper limb. So we see we've got a really large effect size following intervention, as well as their perception of impact on participation. When we look at the Wolf motor function test, the ability to extend the elbow has shown a moderate change. Lifting a pencil, which is really a very hard task, as we saw from Lauren's videos earlier on, showed a slightly larger than moderate effect size following intervention. And overall health was trending towards being a large effect size as well. So we were able to establish through that data that using emerging technologies in a group context was really quite successful from a statistical perspective. So that's one thing, that's the dry data, but I'll show you a quick case study, one that really stood out for me. So this was a young lady who came through our clinic, and she'd sustained her brain injuries a couple of years before she came to see us. She'd had a left MCA stroke on the background of a dissection. From memory, and it has been a few years since I've looked at this data, she was an elite athlete in hockey, and she sustained the injury through whilst she was playing. So it was she was hit by a hockey puck. And it was quite a significant brain injury. When she came to us, she was using a single point stick for outdoor mobility, bit of furniture walking indoors, a really significant right upper limb dysfunction, but not as bad as what you would think. She was your typical patient who had a lot of unmasked potential. So she had a lot of disuse. There was a lot more available there, but she'd very much moved into using her left upper limb for most tasks, but was understandably frustrated. She was right dominant and had some really lovely goals that she wanted to achieve with her right upper limb, and they were things like cutlery use and putting makeup on, which is obviously important for some women. She was mildly aphasic and had an executive dysfunction. Now, this lady, I have to say, lived 2 hours away from our centre. And for her to come in 3 times a week, she had 2 young kids as well. For her to come in 3 times a week involved them getting a hotel and doing 3 days back to back, so that she could come in and have the intensity that she needed. So she showed a really huge commitment to the therapy process. Yeah, we started her off on the ABLX. So on assessment, I mentioned that she had a lot of potential in her upper limb, but she had a lot of disuse. Efforts to incorporate her right upper limb resulted in heaps of compensatory patterns. So the usual stuff that you'd see: shoulder hitching, a lot of trunk movement, really poor ability to actually be able to isolate and be able to use deltoids either in shoulder flexion or shoulder abduction. So we started her off on the bilateral device because she did have some anti-gravity movement available, but we wanted to really do some shaping with her initially, really get her to be using deltoid and getting her into the pattern of doing shoulder flexion and not using her trunk. She showed progression really quickly, so I think it was within about the 2nd week we were able to progress her onto the Sabo rejoist, which is fantastic for her because most of her goals were distal based. So we've got some measures here for the Wolf Motor Function Test. So the blue bars on the chart show her Wolf Motor Function test scores prior to the intervention. I'm not sure if anybody here has used the Wolf Motor Function Test. It's not my favourite assessment, but we did use it for this study. And it looks at 2 components. It looks at time, how long it takes to complete a certain movement, and it also provides a quality measure. And in many ways that's a great thing to have because often we might slow our patients down but get a better quality of movement. So you can actually capture that with this assessment. It was just a real bugger to analyse. Nonetheless, this is her data. So we can see with tasks such as hand to table that it's taken her, if we look at the timing in seconds, it's taken her quite a bit of time, 2.8 seconds, just to do this. Pop her hand up there, which is a pretty basic task. When we look at more complex tasks such as lifting up a can of drink, it's taken her nearly 2 minutes to be able to establish the grasp and lift it. You've got a maximum of 2 minutes to complete each of these tasks. Lift a pencil, she wasn't able to do. So she's scored 120 because that's the lowest score that you can get there. Reach and retrieve, she scored 2.2 and it's taken 64 seconds to fold a towel. That's a bilateral task. So following intervention, these were her time scores. So hand to table, 1 second. It's still slow. Most of us would do it a lot quicker. Nonetheless, it's a huge change for her. Hand to box has gone down to 2.7 seconds. Lifting the can, 65 seconds. Lifting a pencil, so she could do it. And that was important for her because when you think about something like putting eyeliner or mascara on, this is the grip you need to hold your item, hold your piece of makeup. 1 second for reach and retrieve, and 37 seconds for folding a towel. So really significant improvement in timeliness to complete the task. In terms of quality of movement, so the quality of her movement hand to table, it didn't really improve. The timeliness did, but she was still showing a little bit of compensatory movements. But where we see the biggest improvement is lifting the can and lifting the pencil. So she was able to actually establish the appropriate grasp to lift the can. And this is a full can as well, not an empty can, because we all know that sometimes when you put weight in it, that can actually trigger some spasticity or it's significantly more difficult. and lifting the pencil, she was able to establish a really nice grip and hold it up for the period of time. So she wasn't at the top end where it was completely impairment free, but to go from a 1 to a 4 showed marked change. And on the ARMA scale, which is a self-reported measure of quality that I mentioned before, she was initially unable to complete tasks such as opening jars, brushing her teeth, writing or using cutlery. But following intervention, she was able to complete most of the tasks with significant less effort or difficulty. So we can see some big changes there for most of those tasks. It's a really nice measure too. If anybody's looking at a really great subjective measure before setting goals with your patients, I'd highly recommend the ARMA. Okay, so I wanted to talk a little bit about the research practice gap. I think one of the most important things that has contributed to me being able to eventually get funding and get a bit more attention around using emerging technologies was our ability to collect data. Now, our ability to collect data and introduce all of the equipment was really reliant on all of the clinicians actually being involved in this process. And I mentioned earlier on that change is a really hard thing. And I'm a clinician, so I know that. And I know that when there's something new that comes in, you have that sense of, oh God, there's something else to learn. It's a new tool, a new assessment device, or a new piece of rehabilitation equipment. And it can be really tricky to get clinicians on board to take on this change. So I want to talk about the importance of thinking about a framework before you actually go and introduce either a new clinic or a new intervention, and how you can actually get your clinicians on board and how important that is later on if you're trying to get funding. So implementation science research suggests that a framework, some sort of conceptual framework or a theoretical model is necessary to be able to effectively engage your clinicians in change and sustain that change. So if you remember my example about data collection with our hand hub clinic, our hand hub clinic didn't end when we stopped collecting data, it kept going. So our practice change was sustainable. We're 4 or 5 years down the track now, and we've been able to continue using the equipment and continue taking those outcome assessments. And we were quite deliberate in using this sort of framework to get everyone on board. So rather than me sticking the stuff in the clinic and just crossing my fingers and hoping to God that people were going to use it, we were really deliberate in how we engaged our clinicians right from the beginning. So with this sort of model, it looks at how you actually create knowledge. So you start by looking at what your barriers are, and you have to be prospective in that regard. So the barrier might be that, I've got a few clinicians who are really anti-technology, and I did actually have that. So I had to be aware of that in terms of how I was going to roll out my education and how I was going to engage the clinicians and reduce some of those barriers. So you assess the barriers to knowledge use, and you select and tailor the interventions to address that. So for me, it was around looking at what the reasons were for people being anti-technology, and primarily it was based on a lack of confidence, being fearful. Like, you see this big robot or you see this device, and most clinicians are a bit, I can't possibly get my head around it. So I set up Friday trial days where everybody came in and played with the equipment, and I did that over a period of time. And that includes AHAs, OTs, PTs, I really didn't care. It was, anybody who wanted to come in and play with the equipment could play with it, to really reduce that sense of fear and that lack of confidence, getting them on there, playing with it, getting them familiar and confident before they put their patients on there. I created more resources than you can poke a stick at to make life really easy. So things like pathways, decision-making trees. So if you've assessed your patients and they're presenting like this would suggest they should go on this piece of equipment. So really to reduce any of those perceptual barriers of, I don't have enough time. So we looked at it prospectively, we addressed it. We included all of our clinicians in the data collection process. Along with checking with them, well, what do we want to use for data collection? And we tweaked it as we went along. So we changed some stuff. And that doesn't feel it kind of feels like that's a bit wrong when you're talking about research studies, because you think it has to be fixed, it has to be set in stone. But there are different study designs that make it possible to be flexible in how you collect data. So we tweaked our process about 6 months in, on the feedback from clinicians and also on the feedback from our medical colleagues. And that ensured that we had buy-in, and we had really hospital-wide buy-in from all of our clinicians, including our doctors. So the aim of our Hand Hub study was to look at whether it was feasible to actually incorporate emerging technologies at our health service, to look at what the effectiveness was, and I've talked about that, and actually look at practice change as well. Could we get our clinicians to change practice? Could we get that to stick? Would it be sustainable practice change? We had minimal inclusion and exclusion criteria, and we collected data and altered our approach according to what we found as we went along, so we had a really fluid process. We comprehensively collected data, and we still are collecting data. So I'll talk about what my study design was, but the comprehensive data collection is really critical when you take this approach, and it's the point of difference with RCTs and it's why it works in rehab. So the methodology that we used is called comparative effectiveness, clinical practice improvement, practice-based evidence. There's any number of terms that people use for this type of approach. What this type of study approach requires is comprehensive data collection and comprehensive data analysis. So I talked about a few different outcome measures that we used. I think we had a total of 12. So we collected lots of information, including not just at baseline, but all other treatments that patients were undergoing. Were they going to hydrotherapy? Did they have botulinum toxin injection or Botox injections? Whatever else that they were experiencing. And through collection of this data longitudinally, and we're now at the 4th year mark, we can start to see patterns. And we can start to see what is clinically effective for different populations. And this type of methodology sits really nicely within action research framework, and more importantly within a rehab setting, because it's tremendously difficult to run an RCT in a rehab setting. And there's some really nice papers, Horn and colleagues, who talk about this approach being comparative to an RCT. And we were certainly able to publish through using this approach, which, bear in mind, really just involved us collecting outcome data and then just analysing what the results were in the end. So I think that that's important to keep in mind, because it's something that any one of us can do. And I think often clinicians, when they're thinking about collecting data around what they're doing in practice, can feel a little bit put off by the thought of running, a parallel cohort study or a randomised controlled trial. So I would encourage anybody in this room who's looking at measuring effectiveness to take this type of approach. And there is growing acceptance even for granting bodies to look at this type of approach. Not necessarily everyone is wedded to doing an RCT. In terms of establishing your own emerging technology clinic, probably the other most common question I get is, how did we get the money, or how did it start? And I have chatted briefly to a few people in this room, and I did mention earlier on, we had no funding to start with, and I had no extra staff. We started by having the one Sabo rejoice and getting a few other extra bits and pieces in, low-cost items. But I think it's important to have that perspective that you don't have to start with everything. Most of us don't. Most of us don't have the luxury of a huge grant to be able to purchase robots and whatever else, and that's okay. It's okay to add things as you go along, as long as you're collecting data, because data is going to be your best friend when you do start to look at getting grants. And I cannot tell you how much importance that data will hold if you're putting in for a business case, or if you're going to approach your medical colleagues, for example. If you're going to go to them and say, look, I want to get some funding, do you want to support me? Because 99.9% of the time they're going to say to you, well, where's the evidence for this? And allied health just were not that good at finding the evidence or creating the evidence. So it really sits with us to be able to collect that data and be able to analyse that data and show what is or isn't effective. In the same way that Lauren was talking about her Sabo Flex and collecting her measurement data, It's really as simple as that, collecting your outcome measurements pre and post and being able to analyse and show what those trends are. So if there's one thing you can take home from this session, yes, it's that emerging technologies can be successful, but it's the importance of collecting data pre and post. Don't get caught up in what your study design is. That's a really good starting point for every clinician in this room. Who to partner with? Be clever and be brave as well. Don't be too proud to approach people like your head of rehab. And I partnered with our head of rehab, and I literally just said, it was a hallway conversation, let's do some research, because we have clinicians. We're actually the ones that are doing the therapy, and most of our medical colleagues need to publish, want to publish, and for them to be able to run trials, they need us. As much as we need them. So we have access to the patients. We're the ones that are doing the therapy. So be clever about approaching them and like I said, a little bit brave and say, we can do this. I can get clinicians on board to be collecting this data. Looking at local universities. So I have a relationship with a few universities, which has resulted in us getting a robot. And it was just really around offering to do some data collection. And it's resulted in us being able to build the service that we've got, and other researchers. So SaboFlex that Lauren was talking about, we're just in the process of starting a SaboFlex trial, a multi-site trial, and that's really going to be a collaboration with, I don't really care where the site is, private, public, doesn't matter, just looking at how we can pool our data. And just looking at all of us using the same outcome measures that we can agree on, and then getting the actual evidence, getting sufficient evidence to be able to show that it's effective. So being able to partner with other health services that are doing research is a really clever way to be able to get some strength in the data that you collect, because recruitment can take a squillion years, because you don't want to wait all that time to be able to get 10 or 15 patients. And of course, recognising your value. As I mentioned before, allied health have access to patients. We're seeing them every day, or twice a day, or 3 times a week. So we are really ideally positioned to be looking at introducing new interventions and being able to collect data. And of course, our knowledge. We're really good at rehab. So being able to collect data to establish that is tremendously important. We found that our study showed that emerging technologies was acceptable, all genders. The chronicity wasn't an issue for us either. So we had patients who'd had their brain injury 20 years ago, and they showed statistically significant changes coming through the clinic, because we know that neuroplasticity really doesn't end until you're dead. So I would argue, if anybody says it's only 6 months that the upper limb can change, certainly we've been able to demonstrate that more than 20 years post-injury change continues. Staff can be supported to accept change, and emerging technologies are indeed effective. And that's just some future directions of other things that we're doing. We have done an RCT for using this technology at home, and it wasn't successful. So there's something about the group context and patients sharing their experience, which for some reason was a little bit more successful for us. And we've also used the Sabo Rejoice for upper limb amps training with their prosthetic device, and we've published on that, and we've found that it's really enhanced adherence to their training protocol. So there's also the potential, not just for the neurological population, but to use some of these devices for different populations such as amps. That's it.